became interested in surgery probably before medical school. I was intrigued by the lifelong learning that was built into it. I had an operation as a teenager, and I think the most impressive thing was watching the team round every morning, and the more senior people always teaching more junior people. And I watched that every day, and that was baked into everyday life. So the lifelong learning aspect of it was really appealing. The interesting piece of being Indigenous and being in healthcare is, of my generation, most of us learned to hide that we were Indigenous. If you were fortunate enough to be able to hide, you did. So in my training, I would never have openly identified that I was Mohawk. There's another person in my medical school class who was First Nations, and he and I both knew who we were, and we'd talk about it. We didn't let that be open elsewhere. So it's interesting being able to be open about being a First Nations person is a product of being more senior and not being vulnerable. The issue had been when you're in healthcare, you watch all the stigma that gets applied to different groups of people, in particular Indigenous folks. And when you're a trainee and you're junior, you don't want that stigma attached to you, because the people who are training you and who are perpetuating the stigma are also the people who facilitate your career. It's interesting. Lots of people learn to hide. I don't have to hide, in part because I am more senior. I don't have the same vulnerabilities I did when I was a junior trainee. And I also think the landscape of healthcare is starting to change. So there are lots of things where people knew what parts of your identity you were allowed to bring to your profession and what parts you had to hide. And I think that's becoming less of an obvious barrier now. It's interesting. I was in a meeting recently. Someone mentioned that they were the nurse that always got put with the dying patients because they were able to communicate effectively. And I'd actually had that experience a few times in my surgical career where I would be asked to go see a family. I sort of said, so what's the surgical issue? They said, well, there isn't a surgical issue. Their dad is dying and we haven't been able to communicate that. So could you go speak to them? Death is a part of life. Death is as much part of life as birth, and yet healthcare really struggles with it. The interesting thing to me is if you went back 100 years even, medicine really was palliative care. We weren't able to cure a lot of things. Cure wasn't this magical goal. We supported people. We helped relieve suffering. The shift in Western medicine has been the notion of curing things. And I suspect some infections, we cure pneumonias that we didn't used to. We cure infections that we didn't used to. In the cancer space, which is where my first home was, the goal is cure. We don't cure everybody. When we don't cure people, and that's the goal, medicine often provides poor care after that, or has a challenge providing care because the goal was cure. Palliative care is sort of beautiful in that the goal is, I will walk with you through this journey, whatever it becomes. So reframing the goal allows people to refocus their care. That always felt like a bit of a disconnect when we weren't achieving the goal of cure. How were we refocusing to, I will still support you? So I think healthcare has a long way to come in how it approaches death. I actually think, interestingly, the pandemic really exposed that and has started the journey. Palliative care teams got embedded in all sorts of places they weren't pre-pandemic. Emergency departments. The magical tool of palliative care isn't the different drugs we use. It's usually the conversations we have. So being comfortable with the conversations is important. I used to find when I would watch medical trainees, conversations trainees were uncomfortable with having with patients, the patients would feel uncomfortable. We would mirror to them, you should be uncomfortable with this, so be uncomfortable. As people get comfortable with the conversations, we find that families and patients are also comfortable with them. So we get a lot of things mirrored back at us. As we get comfortable with it, people are comfortable talking with us. Funny enough, part of it for me has been being in a place like Toronto. I identify as Mohawk. My family's community is Tyendinaga. I actually identify more as part of Toronto's urban Indigenous community, and that has been a wonderful awakening for me. Toronto's community is diverse. I live and work and socialize with Mohawk people, but I also socialize with Cree people, Métis, and the team I work with at UHN, we often thought we were quite representative of what Toronto looks like. Our team has someone who's Anishinaabe, someone who's Haudenosaunee, and someone who's Mi'kmaq. So we look like Toronto. So the diversity of Toronto has been a really bright spot, and it's actually opened a lot of possibilities. I actually found that the community I most identify with is Toronto's Indigenous community. I think certain things became apparent over time. And my grandmother would have told family, hide your identity. And so much of healthcare made it apparent that you should hide your identity. Once you're able to get beyond that, then you actually go, I want these parts of my life to be able to talk to one another. I have been very privileged to have received medical training and skills and an ability to help others in that capacity. Why wouldn't the natural community I'd want to be serving as a helper in to be a community that I identify with? Yeah, I don't know that it was an intentional at the outset, but it became really apparent because I went into medicine knowing those two things may need to be separate. So once I reached a point where I realized they could work together, then the path became clear. Probably because the real barrier is not what most people believe it to be. If I talk to many of my colleagues, they would say that the access to care barrier for Indigenous folks is geography. Say, well, you live far away. Part of that's perpetuated because so much research is done on remote communities. Why is it done in remote communities? Because it's easy to define that when it's a fly-in remote community, it's obvious this is almost all First Nation people. In the city, we become hard to find. How do you identify a population of Indigenous folks in a city like Toronto? If you don't know how to, we're hard to see. So the challenge is people think the barriers are geography. Most Indigenous folks in Canada live in urban spaces. In Ontario, it's 80% of us live in urban spaces. Our access to care gets worse when we get into urban spaces, not better. Geography isn't the issue. It's systemic issues. A lot of them, the only plain way of saying it is it's systemic racism. There are clear barriers. The interesting challenge is pointing out to people that it's not always about saying, well, there's individual racism, there's systemic racism, there's things baked into the system that often we go through every day and we don't see. They're just part of our background. I find once people see it, once their eyes are open, then they can't unsee it. It's the things that are everyday that are baked in. It's the language we use. There's certain language in healthcare that we think is okay, but the reason it's problematic is you realize we don't apply it to everybody. We use terms like non-compliant. Affluent people rarely get labeled non-compliant. Non-compliant gets attached to racialized people, people who are economically challenged. It gets applied unevenly. When we say things like frequent flyers and emerge department, that term gets used a lot. But what we're missing is people who are using emerge departments frequently, which is true in the Indigenous community, have low connection to primary care. They're using emerge frequently because they don't have other resources. So the language we use in healthcare actually is part of the problem because we've normalized it so much we don't see that. We don't see that we don't apply language evenly. So the challenges are often what's just baked into the system. And the way to ultimately improve it is to start to open people's eyes to it. I think there's another side, certainly around Indigenous issues, which is we constantly have a focus on our deficits, and that precludes people seeing all the strengths in our communities. We have tremendous strengths in how we know, we think, we live our lives, but they rarely come through because we're always framed around the deficits. We have lower this, we have more of that. It gets in the way of seeing where the strengths are. And I actually find once you start to expose the strengths and then actually use them, you start to change the conversation. It's a real recognition that one of the key determinants of health is housing. And not just health, but our ability to provide health care. So we saw that there's groups of people who use an awful lot of emergency resources, episodic care. And the challenge they have is that they have complex health conditions and they're precariously housed. They don't have a stable housing situation. So the ability to provide health care at home to service people with resources, with nursing, et cetera, is impossible when your address is changing or you don't have a stable address. So we know that housing is one of the biggest factors in health outcomes. And we see groups of people who are constantly using emergency departments because we're unable to serve them. So the theory here is that if we house people with complex health conditions, we'll be able to serve them at home in the community. That'll reduce the reliance on emerge usage and improve outcomes, because the truth is emergency departments are all about episodic care. There's no continuity. It's what's the crisis today? What do I need to manage? And then we look at providing ongoing care as supporting people in their home, their set. When you don't have that stable home, I can't do the other part of it. So that's the theory. And the truth is Toronto is not unlike any major North American city right now, where we have sizable groups of people who are unhoused. It doesn't matter what medications I prescribe, what services. If you don't have housing, all the other stuff I'm doing is almost impossible to demonstrate its impact. I often think health equity needs to be framed a little differently. The way it often gets framed as giving people something, as supporting them, gets pushed back around people going, well, why are they getting something everyone else doesn't? So I think the framing has to be a little different, which is equity is actually trying to bring people to the same place. It's trying to overcome deficits that are baked into the system. I think the first piece of that is having to have some visibility into where the deficits are. So when we talk about digital health often gets designed by people who are health literate, digital literate, understand. One of the spaces we need to remember is to actually talk to and surface the voices of the people who aren't digitally literate, who aren't necessarily health literate. Hearing their voices allows us or informs the technology we build. Too much of healthcare is built for people who are well connected, and we resource people who are well connected. We don't hear the voices of the people who aren't experiencing good access to care. And I think that translates also into the digital space, that we need to hear from people so that we overcome barriers like not everyone has access or funds to have a smartphone. So where can we meet people? If I can't meet everyone technologically where they're at, well, how can I take people who do understand and use technology and allow them to use technology to free up resources to meet people who may not be as technologically literate or may not have access to the same technology, essentially redeploying resources effectively. There's an awful lot of things we can do around digital equity. I think one of the first ones is understanding what that equity looks like.